Uh, and now I'll make you host. That should work. Okay, you should now be the host and able to share your slides.
Let me. I need to find my presentation here, and
Yeah.
Super.
can people see that now?
Yep,
Yeah.
certainly can.
Yeah.
And Dr. Strang, when you get a moment, if you could look at the top of the screen and
Yes.
see if there are more people waiting to be admitted to the meeting. You
Yes.
be in control of that now.
I just admitted 4 people. There we
Excellent.
go.
And more may pop up. If you could keep an eye on that, just click admit, and they will be allowed in. Super.
Very good.
Well, it's just a minute past the hour, so we'll give it another 2 or 3 minutes. Not that we want to reward the tardy, but you know, nevertheless. It looks like you're predictably having a very good turnout with over 24 people. So
see us.
Yeah, that's good.
That's great.
Yep.
So, Des, you let me know when you want me to start. And
Yes, I'm just going to do a little brief introduction, maybe at 3 minutes past the hour.
sure.
And then I'll turn it over to you, Dr. Strang. And if you could keep an eye on that bar at the top of the screen so that...
Yeah. There's a couple more people coming
Where
in.
is this being
Great.
transmitted from?
Everybody's home.
It's just,
Like an ordinary Zoom call.
Basket at the bottom.
Yeah. No.
Lots of guests.
And while we're waiting, maybe if you could all mute your microphones with the...
sorry?
You can do it, as long as you got Zoom. I can have a Zoom meeting.
I think maybe Dr. Basket, your microphone is live. Thank you. Anyone else? If you could all mute your microphones, and unless you want to be recorded for posterity, turn off your video as well, because we are recording this session. Excellent. Well, thank you. So it's 3 minutes past the hour. So why don't we begin? And it's my pleasure.
Join the
Oh, we've still got
History of
somebody.
Medicine group.
Well, I just joined this past year.
Somebody's still got their microphone on.
I wonder if that's us.
Not sure who that is. Okay, well, let's try again. So it's just past the hour now, and it's my pleasure to introduce Dr. Strang, we're very fortunate to have him speak to us this evening on lessons from the Nova Scotia pandemic.
That will turn off their sound.
Yeah, no, we still
Won't be able to
still
hear
got
them.
somebody who's got their microphone on. Could you all check your microphones, please? I think it might be Murray Brown. And maybe all switch off your microphones, because we're getting the background sound. Murray, I think yours is still on.
What do I do?
Great, thank you. We'll try again. Okay, so it's my pleasure to introduce Dr. Strang. We're very fortunate to have him join us this evening and speak to the Dalhousie Society for the History of Medicine. Dr. Marble has asked me to do the introductions. He's on the call, but he's busy this evening. And we really are fortunate to have Dr. Strang. We've all lived through this pandemic, and to hear from somebody who was at the center of it is a real privilege. Dr. Strang was born, and this may come as a surprise to you, as it did to me. He was born in Africa. Yeah, and he was born actually in what is now Zimbabwe, but at the time was Southern Rhodesia. And he and his family moved to New Brunswick at age 5. And I also didn't know about Dr. Strang that he's a very accomplished rugby player, and he played rugby for Canada. And for those of you who know your rugby a little bit, you might be able to guess what position he played, and he was the lock forward. And the lock is responsible for holding the pack, the engine room together. So that maybe is not such a surprise knowing what he did during the pandemic. So he is Chief Medical Officer of Health in Nova Scotia. He was appointed in 2007. He received his medical degree from the University of British Columbia and completed family practice in public health and preventative medicine residencies at UBC. He was an associate medical officer, of health in South Fraser Health from 1997 to 1999. And in 1999, we were fortunate to recruit him to Halifax to become medical officer of health for the Capital District Health Authority. He was acting provincial deputy chief medical officer of health prior to that appointment. At CMOH, he has provided leadership around the renewal of the public health system in Nova Scotia, as well as raising awareness around the importance of creating policies and environments that support better health for Nova Scotian families and communities. He's passionate about public health and has worked with non-government organizations such as Smoke Free Nova Scotia, Heart and Stroke Foundation, and Public Health Association of Nova Scotia. He has an adjunct appointment with Dalhousie University, Department of Community Health and Epidemiology. Please join me in welcoming Dr. Strang. Dr. Strang, we're really fortunate to have you and really excited and looking forward to your talk. Over to you. Thank you.
Thank you very much, Des, and thanks for everybody for having me on today. I think this is an appropriate topic. It's recent history, but it is fortunately becoming history in the rearview mirror a little bit. I know some of you I've seen some names that I recognize. Hello to those I know, and nice to meet people that I haven't had the pleasure of meeting yet. So I'm going to spend a little bit of time talking about what I consider our Nova Scotia COVID response and really what we can learn from that. And then hopefully we'll have time for a little bit of question and answer. Let me go to the next slide. Need to figure that out. There we go. So I've done some talks on this and talked to a number of people on this, and these are some of the key questions that keep coming up. People always want to know, well, how did we do in some way comparing to others? And what were those key factors that that contributed to our the effectiveness of response, and what are the things we can learn and perhaps adopt for whether it's ongoing day-to-day care in the health system or being better prepared for the next inevitable large outbreak or even pandemic. And then what are the things that we would like to do differently the next time? It's always important that we're never ever going to get everything completely right, and that's okay as long as we use that as an opportunity to learn and do what we can do to make ourselves a little bit better next time. And then maybe I'll end with a few reflections on how comparing the COVID pandemic to the last major pandemic, which was the Great Influenza of 1918-1919. So I'm going to start with a couple of graphs. I think we always want to be based in some evidence. These are just a couple of key points. And so what the first graph is really comparing, and from the beginning of the pandemic to earlier this year, end of January, it's the most recent data I have. That this is the cumulative number of COVID cases, or the rate of COVID cases, I should say, per 100,000 population. So it's a prevalence, it's a cumulative number of cases. And as you can see that we were, so the green is Atlantic Canada, the blue is Nova Scotia, and we're very close. And then the orangey red is Canada. So And I think it's important to divide our pandemic into kind of 3 years. The 2020 was the year that I call the year of the unknown. And we really had a lot of things that we didn't know about this virus, how it was transmitted, level of severity, who was at greatest risk. We learned as time went on, but there were many things we did early on, especially in the first couple of waves, based simply we all took a cautious approach because of things we didn't know. And looking back in hindsight, perhaps we didn't need to be as restrictive in sort of outdoor activities, things like that. But at the time, we made the best decision possible. Then the year of 2021 was really the year of the immunization, where we really focused on building that very important layer of protection of the population by having as high a level of vaccine coverage that we could. And that was critical. And then Nova Scotia we had some of the highest immunization rates in the country. And I'll talk more about that. And therefore Canada's done very well comparatively. So we had some of the highest immunization rates, especially with our primary series, which still remains the most important 2 doses of vaccine to get in the world. And then 2022 and beyond into 2023 has been this year of transition, where because of the level of protection we had built, especially from vaccination, we could start to be less restrictive. And that was very important because all of our restrictions, everything we did we had to balance the controlling the virus with the known and unknown consequences of the restrictions. So always trying to use the right balance and being the least restrictive possible. And therefore, with a high level of protection in 2022, we were able to be less restrictive. And then we were hit by the Omicron wave, which was highly infectious, and the vaccine wasn't great in preventing transmission, but still remains very effective against preventing severe disease. So you can see that our objective over time switched, but in the first year, we were really trying to limit the introduction and slow down the spread. Really in the first 2 years, as we first of all built knowledge and then rolled out our vaccine program. But as we sort of got into 2021, our objective really became to keep the very restrictive measures, but only as long as we needed them. And that the need really became based on our goal was to get as high a level of vaccine coverage as quickly as we could through 2021. And so we were able to keep our case numbers down very low. And then when we got into 2022, as we lifted restrictions, along with the unique dynamics of the Omicron wave, I don't think any country or any jurisdiction could have kept the transmission levels to the levels that we saw in Nova Scotia and Atlantic Canada in the first 2 years with Omicron. There's also a couple of factors here we need to account for. That because of our relative success in the first 2 years, we had many more people who were susceptible to infection, and therefore our infection rates climbed higher than in 2022 and 2023 at a higher rate than the rest of the country, because in some ways we were catching up in terms of infections. But as you'll see in a minute, we had a different outcome because the protective nature of vaccines against severe disease. The other piece to remember here is we started doing, it really was in 2021 that we started to roll out an aggressive testing program, and we continue to this day to do more testing than other Canadian jurisdictions. So of course, the more testing that you do, the more positives you're going to get. And that also feeds into some of why we have higher case numbers in 2022 and 2023, along with Atlantic Canada, because again, we collectively had more aggressive testing programs. But then when we move to the next slide, if I can get there. 1 second. Why is that? There we go. So this is the next graph is really one we should all pay attention to. And I think collectively, and I'll speak to this later, take pride in. This is the cumulative, that should actually say, that's mortality, deaths. Sorry, that slide, that didn't get translated. This is the cumulative COVID deaths per 100,000. So you can remember how when we had the cumulative cases, we in 2022 and 2023, we had a rapid climb in our case rate. But this slide shows that we achieved our objective, which was to keep restrictions in place until we got high levels of population coverage, on the belief and all the evidence would say that would save many lives, and we did. The Atlantic mortality rate and the Nova Scotia mortality rate, even though our case numbers skyrocketed in 2022, we remain well below the Canadian average for mortality. So if saving lives is your first and foremost objective, then I think we did a good job of that. There has been some literature published, and there was an article in the Canadian Medical Association comparing Canada to other similar countries, size, economics, and other things. And Canada comes out at the top or close to the top on all the indicators that they looked at. They're more comprehensive than the two slides I've shown. And that same group based in Ontario is doing research. I've talked to them about comparing across Canadian jurisdictions. So we'll have more robust evidence, but I think it will tell a similar story about Nova Scotia and Atlantic Canada doing some things perhaps a little bit differently, but ultimately I think, and it's all Nova Scotians did, or the vast majority of Nova Scotians did their part, and we all should take a significant pride in how well we have done in terms of saving lives. So let's move on. What were some of the factors there? Well, first, and to be truthful, we have to admit that we have some advantages which were beyond our control, but we were happy to have them. One was geography, that we don't have, we're typically certainly influenza virus moves east to west, and COVID was pretty similar. It certainly popped up more in central and western Canada, focused mostly on the very large urban centers, very highly dense populations, which we don't have even in Halifax. We're becoming denser for sure, but no, if you understand how this virus is transmitted, and it really is through social connections, then in highly dense, highly urban populations, of course, you're going to have much more spread. And so the other, and a much greater percentage of our population in Nova Scotia is even if we do have relatively modestly dense urban environments, a much greater percentage of our population lives in suburban and rural environments. So we're much more spread out, and so we just don't have the same demographic characteristics, as you will, that allowed that rapid, highly intense spread that happened in major cities around the world. But as I said, also, we were fortunate that we were able to watch things evolve around the globe. We certainly started watching very carefully in public health, right after Christmas 2019, and then watched things move into Italy, and everybody really took note, especially what happened in Italy. But then we also saw what happened in other parts of the country, and we were able to then watch things, and we very quickly understood why we needed to act very swiftly and with almost a lockdown. And I've said this publicly many times that I give the Premier of the day, Premier McNeil, a lot of credit. The first time I met him, he understood the situation, understood the implications. But he said to me, we're going to protect the health and safety of Nova Scotians. Everything else comes second. So you're with me, and you tell me how to do that. And so no hesitation in putting our very strict border measures on from the very beginning, knowing that we we would overwhelm our health system and our communities very quickly if we didn't act. And those border restrictions did play a substantive role, especially in the first couple of waves. And they were very important measures, really stopping people as the vast majority of movement in and out of Nova Scotia helped us slow down the introduction of the virus. So when it did hit, we were able to control it to a large extent. And we also took the approach of, again, because of the same intent of the health of Nova Scotians comes first, that we would respond very quickly. And despite a lot of pressures, even to open up in May and June of 2020, we were able to have this slow, careful reopening for a couple of reasons. We looked at other, even Canadian jurisdictions who opened up much more quickly and more broadly and had rapidly shut down again. And also we learned even from the response to the first wave, where we were slow and we were criticized for being slow. But when we opened in early July, we were able to stay virtually open as a province with some travel within Atlantic Canada. And the economic benefit of that, and PEI in Nova Scotia actually had the best performing economies in the country in 2020. So we were able to mitigate to some extent some of those economic impacts, especially on the hospitality industry, et cetera. And so this is where we came up with this phrase where good public health is actually good economics. And I believe that is true regardless of the issue. When we invest in healthy people and healthy communities, that is actually good for our economy. But that's a discussion for another day. But that experience, especially from wave one, and I'll again credit to the political leaders that they were willing to stand firm and resist a lot of pressure and say, no, we're going to listen to public health. And we learned from the first wave and learned again in the second wave that putting public health first actually has benefits to community and substantive benefits to the economy. The other, I think, key factor is that, and maybe it's due to our size. We, as I said, we started off public health in January 2020, and we pretty quickly we moved into. I went to leaders in the health system and said, we need to start going back to our, taking our pandemic plan from and our learnings from 2009 with H1N1 and start to dust off our pandemic planning, because this is looking seriously. And so early on, we really created a whole health system approach, and knowing that all the parts of the health system had to be working very closely in an integrated manner, and each part of the health system being doing its job in their area to be as prepared as possible. And then pretty quickly on, as we get into late February and then March, realizing that this was going to be in all likelihood a much bigger and broader scope than H1N1, which H1N1 in 2009 was mostly a health system event that we controlled with mostly a vaccine program. It didn't have many impacts outside of the health system, but certainly COVID, I think if anybody's really truthful, nobody in public health or in a leadership position in February, March of 2020 really appreciated the breadth and the depth of the impacts of this virus and how it would touch every government department, every sector of society. But we have very quickly developed a process of engaging. I spent a lot of time in March, April, May of 2020 talking to across government and all their sector groups, talking to universities, talking to various economic business groups, to all the community groups through arts and culture, sports and recreation, all of them, to help them understand of what was going on as best we could and why we needed to do what we needed to do and what we needed them to do. And I think that that collaborative approach, getting almost as many groups and people inside the tent, if you will, and buying into what we're doing, as tough as it was, that collaboration, I think, paid off. As I said earlier, that the vast majority of Nova Scotians did what they needed to do, especially for the first hard 2 years. And that was that collaboration and the time spent getting people engaged and on understanding why and why we needed to do things and what exactly we needed them to do. The other piece, and this is something I really I see some of, and I hope we can continue to maintain this in the health system as we have lots of difficult issues, is the ability to be innovative and have a much higher level of risk tolerance. Typically, in many of you have worked in the health system, it's a big bureaucracy working in government. We're not very nimble, not very innovative, and it's because taking risks has a risk of making a mistake, and we view it from that perspective, and we analyze things to death and think of the 20 reasons why we shouldn't do something. Whereas for COVID, we had many issues, whether it was standing up border control, rapidly developing a vaccine program, testing, all those kind of pieces. That not doing it wasn't an answer, and we had to find out what is the best way to do this based on the current evidence. Let's come up with the best possible model. Let's try it. Let's learn from our mistakes and innovate as we go along. And we had teams of people in various areas that me and my leadership team and other leaders in the health system, we couldn't, and across government, couldn't micromanage all of this. We gave people tasks and say, go do your work. We trust you. And come back and check in with us periodically, but we didn't micromanage, and we allowed them the freedom to be creative, innovative, and take some risks. So I think there's things we can learn from that in general, whether it's all the issues we're facing in the health system, climate change, other major issues that we have now, that we have to be more innovative and creative and more action oriented. As we try to deal with issues and create healthier communities. Another piece, I think, was the consistent communication, the decision again by Premier McNeil that he and I would sit together and communicate directly to Nova Scotians, and we were focused on being open and honest, telling people what we knew, what we didn't know, and again, telling Nova Scotians, here's where we're at, here's what we need you to do and why we need you to do it. And so that, I think, and it was Premier McNeil who made the decision, kind of cleared all the other bureaucratic layers out of the way and said, no, the chief medical officer and I will be, and that was maintained through 3 premiers. And I think when you look at, compared to other provinces where there were differences, if you will, between what the political side was saying and the public health side was saying, all of this was critical. Because everything we did, even though we had it embedded in the public health order, there were a legal basis for it. None of it could have been enforced from a legal or policing perspective. It only worked because people chose to follow the rules, if you will. And I think a lot of that was because of our communication and engagement. But to do that, you have to build and maintain a strong level of trust, and having the premier and the chief medical officer together consistently, I think, was and never publicly being on having a difference of opinion, critically important in my mind for maintaining the trust of the public to keep doing what we're asking them to do. And I put a lot of emphasis on my messaging was that this was about, we needed to do things because in tough times, we need to look after each other. That this emphasis on caring and compassion, putting others and our community first. And I think that resonated with our culture. Nova Scotians have a history of looking after each other. I think it's my own feeling, and it's not my own, it's other people have written about this much more eloquently than I can articulate, but we've grown up by and large in small resource extraction communities where you only survive by looking after each other. And I think that's we were able to tap into that, but it's that sounds a bit deliberate, tapping in, and that was simply a firm belief of mine that we needed to use that messaging. And I tried to carry that message every briefing, ending with some kind of a call for caring and compassion. So those are the factors. What can we learn? I think there's a few things that I've reflected on this. First of all, IPAC is infection prevention and control. That I think, especially in the long-term care sector, we were, as I said earlier, everything we were trying to do was to balance controlling the virus, protecting people from the virus, and that was all based on public health measures in community and then infection control measures in healthcare facilities, hospitals, long-term care. But if I look back, I think we, especially in long-term care, we didn't appreciate at the time the significant impacts of the social isolation and the loss of all kind of connection and activities and recreation for people in the towards the end of their lives. And I think we've had lots of conversations about as well as in hospitals where we had many very sad stories have come to me about people who had a relative, a family member who had cancer and died alone and those kind of things. So yes, it was important to protect people, but I think moving forward, we think, how do we find the better balance of still providing compassionate care, and in the long-term care setting, these are people's homes, and allowing them more flexibility and choice, if you will, to make some of their decisions that may bring them a little bit more risk, but they want to have a better quality of life, if you will. That's challenging in an institution to try to balance individual levels, but we need to think about how we can do that. More broadly, as we're more in this period now where we're certainly everything we're doing is morphing into much more of a generic or general approach to respiratory viruses. The COVID virus will be with us, whether for the foreseeable future, whether it actually becomes seasonal like influenza, yet to be determined. But we need to, again, this is again finding balance, the word I use a lot. We need to still be respectful and careful about respiratory viruses in general. And I would argue that we have been not careful enough about influenza, especially for decades. So how do we find, but we also don't need to be paralyzed with fear and take those strong restrictive measures that we used in the first 2 years. We're transitioning out of a pandemic. So what's the appropriate balance that we have people being prepared again continue to better hand washing, better air ventilation in public spaces, greater willingness to use masks at appropriate times in the year to not so much for themselves but to protect others. Certainly there's a need to encourage a much better uptake of influenza vaccine, and our latest booster doses of COVID vaccine have had less than adequate, I would say, uptake. So we still need some work to do to work with the general public around what is an enhanced approach that finds, again, this balance, being respectful of the virus, but we still have parts of our society that I fear are paralyzed by fear still around COVID. And how do we help them create an environment where they can move them back into a better balance, if you will? There's certainly things we need to do around surveillance and data, not just surveillance for viruses, but, and this is not unique at all to Nova Scotia, we had a very hard time, and we still do, getting data that is can accurately and in a timely manner really help us understand where we're at with the pandemic. And we still are struggling to compare between Canadian jurisdictions because we all collected data in a slightly different way. How we actually define a COVID death, for instance, varies from province to province. So there's lots of work to do at a national and a provincial level around improving surveillance data so we can detect events and earlier, monitor them more closely, but also have a better ability to detect their impact on the healthcare system and other parts of society as well, to better perhaps to help have better data-informed decisions. And I've talked about how trying to hang on to this system thinking and an action-oriented collaborative approach where innovation and risk tolerance is much more acceptable. some of my reflections again are moving beyond the health system. What do we need to think about and pay attention to coming out of the pandemic? Certainly living in a digital information age has had major benefits about communication and connection and the ability to keep many people working virtually and they need to continue doing that for climate change reasons. Also, even in healthcare, I mean, many of you will know we've been talking about virtual care for a decade or more, but making little progress. All of a sudden, the imperative of the pandemic and the need for virtual care kickstarted that. Now we have to be careful we have the right balance of in-person virtual care, but that moving that forward was an important piece. But also the significant negative impact, and it's been studied and written about a lot about living in a digital information age where there's no filter of truth. Even, there was literature research done showing that there were Russian bots that were actually manipulating online content around vaccines. Not that they had a specific perspective one way or another, but they just wanted to sow seeds of distrust in the North American culture, if you will, knowing that would, feed into political challenges and political distrust. And so where is the filter of truth? And, that became really hard. And it's been written about some recent articles about the impact of misinformation and how that had an impact on a range of health issues. So this digital information age is very much a double-edged sword. And I don't know anybody who really has the answer. How do you control the internet? But I think there's a lot of work we need to do. First of all, to how do we communicate more effectively? How do we engage those who are maybe still have a lot of questions, and how do we help them, seek appropriate information and address their needs? There's always going to be a small proportion, and it is very small, but unfortunately they create this dynamic using social media and the digital world that their actually perspective is much bigger than they actually are. But that in itself is an issue. I think we have to understand, mental health has for a long time been underappreciated and under kind of not given sufficient attention, I would argue, in the healthcare system. Certainly, we know the impacts on our collective mental health were substantive from the pandemic, especially in two groups that I've talked about. One, seniors. I think we have had a significant negative impact on seniors, whether they're in facilities or living in community, about their isolation. And they were groups that we specifically emphasized their increased risk. And many of them we have to help now. They still remain at some level of increased risk, but how do we help them feel much safer, and so they can be reconnected, if you will, into community and community supports? Young people as well. I have two daughters, one who went through law school virtually on her own, literally, but went weeks without seeing somebody and doing classes online. And then my other daughter, who was finishing up her high school, and especially for the first year, spent days on end in our basement. And both of them, their mental health were significantly impacted. And I know the literature around, so we've had a major impact on young people, disrupting their very important social connections at a time when they're transitioning to adulthood, and being social is an important, very important part of their role. So we need to pay attention to those groups especially. But this is a call for just another reason to pay more attention to mental health. I think a collaborative leadership, and it's certainly my reflection on being leading in a very challenging environment, is that it's got to be done from a collaborative approach. And I've talked about a little bit about how the amount of time that was put into engaging leaders in various sectors, so they could be leaders in their own sector, but we had to take time to build a relationship. Many of them were tables that haven't really been involved at speaking to prior to the pandemic. And then, as I've talked about, helping them understand what was going on, why we needed to do certain things. I'll use the example, why we needed to close down restaurants. And by and large, we had buy-in from the restaurant sector, as tough as it was on them, because we invested in that leadership with them, a collaborative leadership approach. And then they could be leaders. The leaders we talked to in the restaurant sector could be leaders within their own world. So that a collaborative approach to leadership, rather than even in a crisis period when tough decisions and rapid decisions had to be made. I think that's an important learning, that that collaborative word, rather than a more dictatorial, if you will, top-down type of leadership. We certainly need to invest in preparedness and response. The next pandemic is coming, and it won't be another 100 years from all the as we around the globe, we have more interactions in remote parts of the world of expanding global population with all sorts of yet to be understood, mostly viruses and other microbes in the environment that can then spread very rapidly from a global perspective. We also are already facing significant challenges from climate change that are going to create all sorts of emergencies, whether they're forest fires, heat events, rising sea level. So we need to have much more attention within the health system and beyond around preparedness and response to these kind of crises. I think elder care is an important one. I think we need to reflect. I'll focus on Canada, Nova Scotia, that the way over the last several decades that we've built up our elder care, which is for many people, very institutionally based. People are disconnected, they don't have immediate family, all those issues that, quite frankly, create environments that are inevitably and inherently have an increased risk for transmission of viruses. So we need to think about our value of our elders and how we actually provide care for them. And again, finding this balance around, yes, we need to protect them from viruses and other things, but also have better quality of life, better social connection. And maybe we need to think about different models of care that are on a much smaller scale, that we don't have large populations all very vulnerable. I think we also need to think about the caring, what's the term that's been used as the caring economy, that COVID has highlighted that we have positions in our communities that are all based on caring, whether they're continuing care assistants in long-term care, nurses, physicians. We have many people who are vulnerable from types of disabilities who live in community. We have continuing care, teachers, and then care aides in our school system. We have early childhood educators. Those are the ones that we asked them to keep working, because we needed them. We needed to provide care. We needed to provide health care. We needed our kids, the best place for them to be as much as possible was to be in school, which means we needed schools to be open. And we knew we needed daycares to be operating, so all those people, many people, could go to work in other parts of healthcare and beyond. But these are positions which we have historically, they're very often, they're gender-based, mostly female. Very often now there are people from other parts of the world coming to that we're actively recruiting here, and they're very often lowest on the socioeconomic scale because of compensation. So I really think this is a call for us to place much greater value and show that value through enhanced training to be able to provide better care, and then a compensation that reflects that enhanced training, so people can actually choose to make a career out of being a carer. I think that's an important conversation that we're making some progress on it, but I think it's a very important and large topic. And the last piece on this is this sense of caring and of community and coming together. We have many challenges in front of us, whether it's climate change, whether it's affordability, huge challenges around housing. how do we actually be much more collective and community based in our approach? And I use the term common sense as well, because I've got a binder full of things where I just felt, boy, you really need to ask me that question. Just think through it a little bit and use some basic common sense that we tend to have people lost their heads. And I think part of it was, people became paralyzed and they felt they needed to be told how to do everything. So that's a bit of a lesson learned as well about how do we continue to maintain people's common sense and a sense of independence while we're being more prescriptive in what they can and cannot do. But this whole thing around putting the collective first, if you will, is a very important topic to me anyway. I think it's something we're in a very individualistic based society that we need to reflect on. And close to the end, so how do we, just thinking about, and although I may look at after the last 3 years, I was not around in 1918, 1919. But how do we, when I think about it and read a little bit, we have vast differences in our ability to provide health care to people who became infected with COVID versus Spanish flu. I mean, one of the major causes of mortality in Spanish flu was secondary bacterial pneumonia, which we have very effective treatments for now. But it's interesting that even though we had vast differences in our ability to provide care, ICU care, modern antivirals, all those things, that are, when you look at it, our fundamental public health control measures were very similar. We had to basically have people disconnect from each other, disrupt social connections, cut things down, limit travel, close down schools. I mean, when you go back and look at, there was a very interesting display. I don't know if anybody saw it a year or more ago at the Public Archives, where they had some of the materials that we were using currently for this pandemic, and they had some things that they brought out from the Spanish flu, and very similar messages about wear your mask, don't go, closing down churches, closing down schools, stay home, all those things. So our basic public health measures remain the same, even though we're at a much more sophisticated health care environment. So I think that's a very interesting kind of reflection. And some of the societal responses are very similar. There were anti-mask people back in 1918, 1919. And I think people got very fatigued when you read some things about towards the end of, because we don't hear very much about the Spanish flu. It did go into 2020, 1920, but the stuff that I've looked at, there's a general sense of fatigue as well. So many of our public health approaches and then societal responses were actually remarkably similar. But I think some of the key differences were, first of all, the ability and the speed of spread, because we live in a globalized environment with travel of people and goods. Something can happen and has happened both in SARS and back in 2003, and again with COVID, which is a SARS virus as well. That things can happen in China and within days there are other parts of the world. We certainly have a much greater ability, even though I talked about the need for further improvement, a much greater ability to detect these events. But as we've learned yet again, that our surveillance ultimately relies on global cooperation and rapid sharing of information. And I think nobody really knows all of the facts, but certainly there are lots of evidence that would suggest that there wasn't the better communication and better sharing of information out of China earlier on would have helped. And I think that again, this social media and the digital age and how it has fostered disinformation and misinformation, very different than 100+ years ago, where even though there were anti-mask, anti-vaccine sentiment, there did not have the ability in terms of speed or breadth of spreading the message that we have today. So though I don't know what we do about that, but to me, those are some key things to reflect on about how we were both similar, but also different between the Spanish flu and COVID-19. I'm going to stop there with my slides, and hopefully we haven't gone on too long. And Des, I'm happy to take some questions.
Perfect timing. Thank you very much for that really, really interesting talk. And thank you very much, Dr. Strang, for your leadership and your incredible hard work and devotion during the pandemic, for which we're all indeed grateful. I'm going to reclaim the host function here. And while people are getting their questions ready, can I ask you one? What was it like on a personal basis to be at the center of this storm? You mentioned your daughters, but what was it like for you?
2 years of 24/7, just never shutting down. And but a few things that kept me going. You know, I worked closely with a handful of 6 amazing, all women, in as leads in the COVID response. And we couldn't have made it without each other, because we kind of held each other up. We laughed, we cried, we yelled and screamed about various things to each other, but then got our composure and went back out at it again. The other thing was coming home, my family, and able to have support there. And we got so much support from our community, meals, gifts, baskets, all these kind of things. And the last thing is, I'm a person of faith, and ultimately I felt that to me was, I knew that I didn't ultimately have to carry all the weight of this on my shoulders. I could do my job, but at some place it's out of my hands and to what I believe, to God, whatever people believe in higher power. And that to me was very, if I hadn't had that, I'm not sure that I would have kept my head above water.
Remarkable. We all owe you a great deal. Dr. Murray.
Yes, thanks, and Rob, thank you very much, not only for this talk, but for all you and your team, and I guess everybody in the healthcare system has done over the last couple of years. I wanted to pose this question, trading on what you've learned during the pandemic. And right now, equal or probably greater than COVID is our crisis in primary care. And wondered your thoughts in applying a lot of the lessons from public health to primary care, and how you see that evolving over the next little while. You've probably been thinking about it and undoubtedly having conversations about it.
Yeah, and nice to see you, Tom. Thanks for that question. That's an easy one. No, I mean, I'm not directly involved in that, but I think there's some things we can learn. Is that we had to, like we did for the COVID response, and we had to figure out testing, access to vaccines. That's a lot of that is in the space between public health and primary care. And I think we need to be doing some of the same with that innovative, creative kind of approach. Let's try something. Let's not be afraid to fail. Failure is not, we are not going to get it completely right, but all that means is that we have things we can learn from. We've been trying to fix primary care since I've been around and before. We're talking about the same things that we haven't done for 20 years. So that action-oriented, innovative, creative, take risks approach, we need to do the same. And we need to bring, I think, that sense of what I talked about, Nova Scotians coming together. The health care system and how people in the healthcare system all came together collaboratively to do what was needed to be done, whether it was getting vaccine programs going, standing up innovative testing approaches to testing the public, to all of what I know from talking to colleagues have had to turn the delivery of care, shutting a bunch of things down, but standing up a bunch of other things to provide for people with COVID. We can do this. I think the challenge is too, people are extremely tired. There's a lot of people that perhaps don't have it in them again. And the human, and partly because of that we now have a huge human resource challenge just to get the people in place. But to me, the answer is that still focusing on that. Let's be action oriented. Let's try things out. Let's learn from them, and that strong sense of coming together collaboratively, as opposed to being more in our silos and fighting over professional turf.
Thank you very
Thanks.
much, Dr. Strang. Dr. Geldenhuys is here, Head of Pathology at the Health Sciences. Lorette? I think you're on mute, Lorette. Or at any rate, we can't hear you.
Is this better? Can you hear
Yep.
me now?
Yes, I can hear you now. Yeah.
Phones. Sorry about that. Thank you so much, Dr. Strang, not only for an absolutely excellent overview of COVID and your experience with it, but also for everything you have done. I think as Nova Scotians, we felt incredibly fortunate to be taken care of by you. So thank you. I have one quick question, and that is about the negative mental health effects of the pandemic. I read actually in the Medical Post that there are some studies showing that it is not universal that people have had decreased mental health because of the pandemic, but that there are many people, and I don't recall exactly what proportion, but that many people actually were not significantly negatively affected, and that there are some people whose mental health actually improved, perhaps through things like being able to work from home or having decreased pressure to do various things and so on. And I wonder if you're aware of any of these studies or any comments on it.
Yeah, no, I think what I'm aware of is mostly the very preliminary studies showing the increased numbers of people seeking care for mental health and on an already burdened system. I think it'll be a decade or more before we tease out many of these real impacts. I completely agree with you. I've had lots of people in conversation with them saying that they're never going to go back to having their lives as busy as they were pre-COVID. They've found the COVID has sort of shown them about finding a better life balance. So it's not for, there haven't been negative impacts for everybody, but my point was on pre-COVID, we had significant challenges, especially in young people with mental health and substance use issues. Those have been exacerbated, and very often on a kind of a social gradient perspective as well, that we need to pay attention to. But you're absolutely right. It's not universal, and so what can we actually learn from those people who actually benefited? And maybe there's things that we can apply to help those who are struggling right now too.
Thank you.
Thank you very much. Dr. Strang, there's a recent Cochrane analysis on the efficacy of masks. What's your take on the mask story?
Yeah, I think that Cochrane analysis has been, if you look carefully, it's been pretty debunked, very selective use of the literature, and some of those people doing that analysis have well known to have kind of a preconceived bias. They're also the same group that have done analysis showing no effectiveness from influenza vaccines. So masks aren't, I think the conclusion, masks aren't the be all and end all, but masks certainly play a role. But again, we need a layered approach that's improving ventilation, where necessary, decreasing social interactions, but having people masked where necessary is an important place. I think we need to look at where masks, I don't think we no longer need everybody be wearing masks in indoor places everywhere. We're moving away from that in a public health message, and even in healthcare. I was reading something today where we have stronger masking mandates still in Nova Scotia from an infection control perspective than the rest of the country. So I think we need to, even in healthcare, move to a more risk-based approach based on a careful infection control analysis, and rather than having just these universal approaches. So I think masks play a role, but again, it's that mold is one of many pieces that you need to have in place for effective interventions that minimize the spread of a respiratory virus.
Super, thank you. Dr. Strang, if we may, it's coming up to the hour, but maybe we'll take one last question. David Clark.
Hi, Dr. Strang, David Clark. I'm from neurosurgery. I enjoyed your presentation very much and join others in thanking you for your efforts. One thing that perhaps wasn't mentioned in terms of the effect on the healthcare system is, and this is a follow-up extension maybe of Tom Mary's question, that I think the population became detached, if you like, from an already fragile medical system. And certainly we've seen people coming in with very late pathology, and certainly, you know, there is a morbidity and mortality to be accounted for by needing to implement such strict healthcare measures. And I wonder, I know that's all part of the balance that you were talking about, but is there some way of quantifying that and other lessons to be learned from that?
Yeah, I'm not directly involved, but your points are good, and I know there's research going on looking at excess mortality and trying to tease out what are the different causes of excess mortality, and continuing that research even as we come out of the pandemic. What are the things that are resulting? And there's a lot of, I'm certainly aware of some pretty solid evidence that increased cardiovascular disease, increased myocardial infarction deaths, etc., coming from people delaying care, you know, more advanced cancer diagnosis, etc. Similar to my answer around mental health, I think it'll be a decade or more before we really truly tease all of this out. But again, I think it's an important reflection. We shut everything down during wave one because there's so much we didn't know, including access to most healthcare. So maybe, you know, we need to think about that. And do we need to have them next time around? A lot will depend on the exact virus and characteristics, etc. But I think there's a lot we learn, these unintended impacts that we need to, which should inform the choices we make next time. And maybe even if we make the same choices, we're making them in greater knowledge of the consequences that may come, and how do we then mitigate some of those consequences.
Thank you very much, Dr. Strang. So we'll come to a conclusion, but before we do, maybe I can tell you about a presentation which is coming up next, and that will be from Emma Martell, who's a student doing fourth year for undergraduate degree at the University of King's College. She's pursuing a minor in history and technology. The presentation will be part of an archival-based research project funded by Research Nova Scotia. And the project examines, appropriately enough, as a segue from this, influenza-focused advertisements in Nova Scotian newspapers from 1918. And the goal of the project is to demonstrate how these advertisements placed a moral imperative upon women to keep themselves and their families in good health. An especially important task, as she says, given how saturated the newspapers were with advertisements. So maybe I can highlight that for you, and perhaps if you're available, you might want to log into that, what promises to be very interesting. Dr. Strang, we should conclude, and again, I'd like to thank you on behalf of all of us for giving us your time this evening and for your incredible work during the pandemic. Thank you very much.
Thanks very much. Wish everybody a good evening. It was a great opportunity, and I was just the front public-facing person, but there are hundreds of people that I worked with that deserve the kudos to their contribution. And again, all Nova Scotians, including yourselves, did what we needed to do for especially those 2 years of really tough times. But everybody stood up, and so we should all congratulate each other and be proud of what we collectively achieved. So thank you.
Thank you very much. Good evening.